All right. I think we'll get started. Good afternoon, everyone. I'm thrilled to welcome you to today's insightful webinar, an interdisciplinary approach to palliative and end-of-life care in long-term care, hosted by Ontario Seniors Nutrition and Advocacy Committee, OSNAC for short. My name is Amrit, and I am going to be your moderator for this event. So before we dive in, let's cover some housekeeping rules for this session. To ensure a smooth experience, we have arranged for audience cameras and microphones to be turned off during the session. The chat feature is disabled, but don't worry, you do have access to a 30-minute Q&A session, which has been planned for at the end of the presentation. During the Q&A, please feel free to use the Teams Q&A feature to pose your questions. If you spot a question that you love, hit that like button to give it a little boost in priority. You are welcome to enter questions during the presentation as well. However, the questions will be addressed when the presentation is finished. Given our large audience, we might not be able to address every question, but we will do our best. We may group some of the questions by theme to cover as much as possible, but we will also attempt to send out a summary document afterwards, time permitting. Please note that this webinar is being recorded, and the recording will be available at the OSNAC website in the coming days. At this point, I would like to say a massive thank you for our partners and presenters. We truly appreciate their support, and without them, none of this would be possible. To start, I'm going to share some information about who OSNAC is. OSNAC was established in 2020, previously known as Dietitians of Canada Ontario Long-Term Care Action Group. OSNAC is run by volunteers. We have an amazing group of dedicated registered dietitians and nutrition managers working at the corporate and frontline levels of the senior sector. Our purpose is to advocate, educate, and empower to strive for updated regulations to meet changing needs of our seniors, to enhance person-directed care and quality of life, and to advocate for flexibility at the home level. Now, without further ado, let's introduce our fantastic speakers who will be sharing their expertise today. We have Heather Toll, a registered dietitian, and Stephanie Burkus, a nurse practitioner, joining us. Heather has been a long-term care dietitian for over 20 years and is passionate about educating around food for comfort and quality of life in palliative care. Stephanie has her CNA certification in hospice palliative care nursing and has been practicing in long-term care for over 7 years. Both Heather and Stephanie are strong advocates for an interdisciplinary holistic approach to palliative and end-of-life care. At this point, I'm going to turn it over to them to get started. Heather and Stephanie.
Hi, everyone. I'm just going to turn my camera on here, and Stephanie, please let me know if it's freezing. My apologies, I'm having some technical difficulties. Can you hear me okay?
Yes.
Stephanie and Emmerich, can you hear me okay?
Yes.
Okay. Yeah. All right. So today's objectives, we're going to cover a review of palliative care and end-of-life care and how historically that's evolved over time in long-term care, also highlighting the differences between the two. We're also going to look at the benefits of early identification of health decline. So trying to create that culture that supports that early identification and education to residents and families. Looking at the importance of supporting an interdisciplinary focus for palliative and end-of-life care. So highlighting some of those team members that are crucial in having those discussions as someone's health status declines. We'll also have some resources and policy and education suggestions that we have for you. And then we will open it up for a question and answer session thereafter. If we take a look at palliative and end-of-life care and kind of highlight the differences and where we want to move towards, palliative care used to be more of a philosophy of more of the end of days and looking at kind of doing less. We want to move away from that thinking where palliative care means doing less or giving up. move away from the thinking that palliative care means that we stop all treatments. And we also want to move away from thinking that death will approach faster if we provide palliative care. What we want to move towards is looking at symptom management and the relief of suffering. We want to focus on having early discussions and identification of different needs that the residents may have, whether it's physical, psychosocial, spiritual, etc. We want to focus on quality of life when someone has a life-limiting illness. And we also want to think of palliative care as a philosophy of care. So this is something that can last quite a long time. It can last months, if not longer, throughout someone's disease trajectory. And when we're referring to end of life care, we're referring to those final weeks, days, hours of life where we're more focused on symptom control and not necessarily the life closure events that we're going to be talking about more so through the palliative care journey. Just want to mention here that the Fixing Long-Term Care Act 2021 does outline some minimum expectations for a palliative care program. Some of the things that it mentions is that we want to be able to meet each resident's palliative care needs, that we do want to do an interdisciplinary assessment, and we'll touch more on the interdisciplinary piece throughout the presentation. But we want to make sure that we're focusing on considering the resident's physical, emotional, psychological, social, cultural, and spiritual needs. And then at minimum, we want to provide them with options that include quality of life improvements, symptom management and control, psychosocial supports, and then transitioning towards end of life care as appropriate.
Okay, so what we found was very helpful was that early identification. So being in long-term care, you know your residents really well, and we can start to see those changes that may start months before end of life comes. So what we have tried to instill in our frontline nurses, even in our PSWs, our whole team, is let us know when things are starting to change. So we get those early cues of someone who maybe is starting to eat less, the weight loss, sleeping more, increases in things like edema for CHF. So we're really wanting our team to let us know when there's changes. So we found that these early identifications get us to have those early discussions with family and with the resident. So we found that having these early identification and discussions, we can improve symptom management. If a comfort measures approach is chosen, we can start to address all those pain, shortness of breath, all those symptoms we're worried about. We can get them earlier access to our community partners. A volunteer from the Victoria Order of Nurses, for example, can come and start visiting with them. One of the main things we found is it really does reduce our emerge transfers. So if we can stay within the home, if the goal is just symptom management, that is something we can provide. They don't need to go to emerge for that. And we can kind of touch base more frequently to make sure we're meeting their goals of care. Overall, it does seem to improve their quality of life, and it really, really assists families to help them with the transition towards end of life. Another thing we found when we're having a team approach to everything is that the consistent messaging. So they're not having a nurse on the day shift say, "Mom's doing great today," from the nurse on the evening shift saying, "Oh, Mom's not looking so good today." So that we really help them to see that consistent messaging, and that really helps families as well. So again, we want to focus on that interdisciplinary approach. So we are really recommending that if within your homes you don't have a palliative care team, that this is something to think about. And we would encourage you to gather as many people from as many disciplines as you can. So it really shouldn't be a team just with nursing. We really suggest that you involve, of course, the RD, social worker, frontline nurses, NP or MD, and we'll touch upon kind of all of their roles there. So what we found that when we are using our whole team and all their specialties, we can consider all those aspects. So maybe myself as the NP, I'm not too much considering the spiritual aspect, or the RD is focused on hydration and nutrition and maybe not the medical piece. So once we all come together, we provide a much more holistic approach. We can lean on each other as professionals. We can say, "Oh, I'm not too good at this family grieving piece, but my social worker really is." And so getting everyone on the team, everything is more timely. We're not waiting to get the social worker up to date on what's happening with this person. You know, she's been involved the whole time. And again, that holistic approach really, really helps to help residents and families accept, you know, what's going on and help with the grieving process, and helps everyone get through this a little bit easier.
So we're going to take a look more at role clarity now. So obviously this is not set in stone. This is just some suggestions that we have, but we did find it was really important to actually specify what general roles someone would have within the palliative and end-of-life program. And then we try to incorporate that philosophy within our team meetings. So some suggestions we have for you to consider would be, if you look at your nurse practitioner or your physicians, this group of people are able to flag unstable residents, anyone with worsening medical conditions, and it's really key to know about those early. So empowering them to share that information. They can also look at symptom control issues, and they can be promoting standardized use of medications. So for example, we created an end-of-life care order set that we use, and it's a standardized approach to symptom management for end-of-life care, and it's based on best practice. That doesn't mean that everyone will be able to fit that mold, but it does mean that we would have those medications available in a timely manner to help relieve symptoms at end of life. We also know that this group is the nurse practitioners and physicians are very involved in resident and family education. So just empowering them to do that and then share that with the team. As for the registered dietitian, we know that that role tends to focus on the eating and drinking piece as well as weight management. It is important to note that typically as diseases progress and go into the late stage, eating and drinking tends to be the last thing to change. So it's often really important to have this key player involved in the discussions, because they would have an idea about the eating and drinking patterns. They would know more about whether or not weight loss is occurring and whether interventions could be successful or not. The registered dietitian can also provide early education about swallowing issues, or dysphagia as we call it, especially as someone is moving through their disease trajectory. It's really important to have these conversations about what might be expected in certain disease processes, for dementia, for example. And then dietitians can also provide education around the contraindications of artificial nutrition and hydration. So we don't have time to get too far into that, but just knowing that typically when someone's receiving end-of-life care, it's contraindicated to provide artificial nutrition and hydration from a quality of life perspective. But if those conversations are happening earlier, we can really establish those goals of care for nutrition and hydration early in the process. Looking at our registered nurses and our registered practical nurses, they're obviously highly involved in communicating changes that they see to the medical team in the resident status. They might be the first to notice changes in their activities of daily living. They can provide updates and educate family on what they're seeing. They can coordinate symptom control issues, so bringing that to the medical team's attention, and also flagging any concerns to the allied health professionals so that people can follow up and provide that holistic type of care. They also monitor the disease trajectory. So here at Hillsdale Terraces, we adopted the Palliative Performance Scale a number of years ago. Again, we don't have a lot of time to get into what this scale actually is, but it is used as a communication tool so that we are all on the same page with where someone's at in their disease journey. And it's fairly simple to complete. So it's something that we use on a regular basis when we're communicating about a resident's health status. Also at the Terraces, we use a clinical lead RPN as our kind of program lead on the nursing side. They adopted that model so that the palliative program did have a lead nurse point person who would do auditing, policy suggestions or changes to policy, looking at providing education to staff, and then supporting families at the bedside and residents as well as someone's transitioning towards end of life.
So just to highlight a few other team members that we have on our team here. So of course, the social worker we had talked about. So a lot of psychosocial support. She's our link to community partners such as Victoria Order of Nurses and their grieving and volunteer supports. She links to our community spiritual needs with different churches in the area. And she's kind of our point person when we want to organize those care conferences and touch base with families. And of course, just overall support, psychosocial support for the families. We have 2 PSWs on our team here. So our PSWs really are helpful to us with any kind of symptom management. They're also speaking to families and residents, the most throughout the day, so they can alert us if there's any concerns that way. They are educated in palliative care through the LEAP course, so they know how to communicate therapeutically, and they can pass anything on to our team in terms of resident concerns as well, same as the nurses. We have recreation team representatives as well. They again help with spiritual needs as needed. They can, if someone is not getting out of bed anymore, maybe does not have too many family, they can sit with them, provide one-to-one visits. They can set up things like music and all those things that may be needed. And not to overlook the contributions of our food service staff and our environmental service, such as housekeeping. So again, they're in the room. They're seeing families, they're seeing residents. They also have some input into seeing changes that happen. They also need to understand this kind of philosophy of palliative care, so that when they're asked by family about, how's mom doing today, then they can have the proper discussions too. So we need to emphasize like how much any person that interacts with the resident and family is involved in this process. So just before our case, so just to give you kind of a picture of that. So all these team members that we had discussed, so once a month we do meet as a large group. So if needed, we meet maybe in smaller groups. If there's like a decline that happens quite suddenly, then we will, of course, follow up on that as needed. But routinely, once a month, all those members that we just mentioned, we meet kind of around the boardroom table once a month. We are flagged to, half a dozen residents that we're concerned about. We discuss each one of them in detail and where they're at in their trajectory and where their needs are. Do they need more symptom control? But is their symptom control okay, but they might need more spiritual needs? And we all kind of contribute to that discussion to make sure things are holistic. Okay, so we just wanted to go through a quick case to kind of put everything, maybe you can visualize it better once you kind of think of your residents. So this is one that those of you in long-term care are very, very familiar with. So it is an end-stage dementia death. So this kind of resident maybe came into your secured unit, perhaps. They were ambulating. After several months, stuff happens that happens in this disease processes, frequent falls, maybe there was any kind of infection. And as each of those scenarios played out, the resident got down and down in the PPS. Maybe they are wheelchair bound now. Their ability to feed themselves has declined. Their dysphagia has increased. And now they're sitting at a 30% PPS, which is no longer ambulating, total feed, total care. So at this stage, as Heather had said earlier, when it's end-stage dementia and they get to a PPS of 30, the main driver is the intake. So the dietitian has a real big role in our end-stage dementias in that it's looking at the weight and the intake. So in this case, the RD did her assessment. She saw this gradual weight decline, and also on a swallowing assessment saw that there is increased dysphagia. So those are the residents that went from regular diet to minced, and now they're puree and thickened fluids. And now we're seeing less and less intake and more kind of lethargy. So once we started seeing these signs were kind of flagged to us, we brought it to the table. Let's discuss what's happening here. So because we see that this is end-stage dementia, the MD and NP can look at blood work, make sure they don't think anything else is going on. We always rule out acute first, of course. We've ruled out that there's nothing else going on. This just looks like end-stage dementia progression. We set up a conference with the family. We had, whoever wanted to be there. And that's another part of these discussions is that you're not just calling the power of attorney. If the power of attorney if there's several children involved, we welcome if they would like to invite their siblings. And that also helps us with that consistent messaging. As you know, sometimes power of attorney is not passing things on, and then you get calls from this brother, that sister, and everyone's getting different messages from different team members. So we invite whoever from the family would like to be on the call. So we had goals of discussion early. We said, this is happening with mom. Things are progression. We believe it to be dementia. Things are going to continue to get less and less. What would you like to do? And the goal was, the decision was comfort. So the family decided that comfort and palliative care within the home is what they would want. They don't want to send her to hospital, and they didn't want any extra interventions. So once we had that in place, we can also put that kind of communication on for the team to know. And then as things continued to progress, family was aware it was going to happen. And all we were doing is keeping them kind of alert that, yeah, things are progressing as we had discussed. And as things came closer to end of life, so maybe feeding had stopped, then we would look at, alerting them that, we feel it might be kind of days from now. They can kind of plan their visits around that. And of course, along this whole trajectory, we addressed any symptom control, pain issues, that kind of thing.
Okay, thank you for that great overview of the case, Stephanie. Some other resources and communication tools that we have that we can mention is that, as we've said before, we do use the palliative performance scale here at Hillsdale Terraces. We've used it for quite some time, so we have built kind of a culture around its use. Initially, when you introduce it, it does take some time for people to get used to it, but it does allow us to communicate how a resident is more tangibly doing on their disease trajectory. It's a scale that ranges from 100% to 0%, 100% being very well, no issues. There is not going to be anyone who's at 100% in long-term care. Typically, they're around 50 to 60% if they are fairly high functioning, and then a lot of people stabilize around 30%, and then they drop more towards receiving end-of-life care as they become unstable, dropping from 30 down to 20 and then 10%. And then the person passes away. So it has been a great tool for us just to ensure we're all on the same page. So we do strongly suggest you take a look at it. You can also use empathetic communication techniques. We do find that a lot of staff do struggle with having difficult conversations. So there's a lot of great education out there, but we do try to use what we would call the wish, worry, and wonder technique, where we're trying to establish, that we understand people's hopes, but they're also giving them some truth. And then we're making some recommendations. So, I wish things were different. I worry, though, because you have quite a few health issues that you could get sick very quickly. I wonder if we could talk about a plan, or if you're willing to talk about some options. So those are the type of communication techniques we do try to use to try to be more empathetic. And then you can look at things like spikes. It, again, can't go over it in detail, but it is something that helps you to set the stage, to have an environment that's more welcoming, and that you're reiterating the conversation and you're summarizing, being aware of emotions, and so on. We do use a lot of these educational resources. We've got some great access to education in Ontario and in Canada. Hospice Palliative Care Ontario is fantastic, and same with Pallium Canada. As well as Canadian Virtual Hospice. They have a learning hub, and the CLRI, so their Centers for Learning, Research, and Innovation in Long-Term Care, has some great education. They have a module course, an e-learning series that's about communication at end of life, that can be accessed. And then also OSNAC, the Ontario Seniors Nutrition and Advocacy Committee, does have the nutrition and hydration best practice guidelines for palliative and end of life care.
Okay, so if you are, again, just kind of starting out your team, or thinking your facility would benefit from starting a program like this, so we would suggest you start to create that culture and that knowledge around the difference between palliative and end of life care. If someone is kind of actively dying, we're using end of life. But if someone is end stage dementia, like our case, but they're still maybe months away from passing away, and the family has chosen comfort measures, then we're using words like palliative. So kind of instilling that so that your staff is using the right terms with families and residents and with each other. We really want to see our frontline people educated this way. We don't want to be you know, the be all and end all of our program. We want to be a resource and available at any time, but we really want our registered staff to be there if something happens on a weekend or on a night shift. The staff really need to be educated in this way. So again, establishing that team, get as many different disciplines on there as you can. You know, get all the dietitian, NP, social worker, recreation, PSWs, get everyone there around the table. And we also really suggest that you start doing these care conferences if a decline is possible. If you start to see that starting, there's no harm in saying we're starting to see decline. We don't know what's going to happen. This could be just a bad patch, and they could bounce back, but they could not. So we just want to know what you guys are thinking, where your head is at. We just want to know, you know, if things do start to continue to decline, that you've thought about what mom would want at this stage, right? So getting those care conferences in, getting families thinking about things, okay, and just that education and support once we start to see that decline.
Some other suggestions, linking with community partners. The Terraces has linked with VON, as Stephanie had mentioned previously. We are very lucky to have hospice volunteers come into our home from the Victoria Order of Nurses. They also give us access to grief services as well that they offer throughout the community, and it helps us to advise our family and residents of what's available, in addition to our internal supports. And we do also have a great volunteer coordinator who has looked at our current volunteers and asked if there was an expression of interest if anybody wanted to become a hospice palliative care volunteer. So we do have a few internal volunteers that have been trained as well. We would encourage you to reach out to your residents or family councils. They're always eager to hear about what's going on in the homes, and they can contribute in any way, shape, or form to the way the program works as well. And then we would also suggest monitoring some statistics as a part of your program evaluation. So some of the ones that we've looked at in the past is our hospital transfers, looking at those who have a score of PPS, a PPS score of 30% or less, and if they've gone to the hospital. Usually if someone's declining below 30%, a hospital transfer is not likely warranted. Again, there would be certain circumstances where it would be, but looking at those hospital transfers and evaluating that statistic. Looking at the goals of care discussions that have occurred and whether or not it coincides with someone's decline on that PPS scale. Also looking at implementing a standardized end-of-life care medication order set, and then using this to also monitor symptom control at end of life or throughout the disease trajectory. And then also looking at deaths within the home versus deaths in hospital, as that's typically preferred to die in home versus in hospital.
So this is a lot of work. So why would we do this? Well, it's very much worth the effort. So in all the surveys from CIHI, of course, people would prefer to die in their home. And this, of course, in their long-term care home is their home versus hospital. The statistics are not great for our senior population and receiving proper palliative care. So if it wasn't a cancer death, then they were less likely to receive good palliative care, good symptom management. So we want to be able to change that. So because we work with geriatrics and we can provide that palliative care, we want to do that at any opportunity. We did do some look backs once we started our program. So we did see that once we got into this habit of education, care conferences, multidisciplinary team approach, we had some successes. So we increased the use of that order set, so better symptom control. We decreased our hospital transfers within the last 30 days of life, and we increased by a huge margin those care conferences where we all were able to touch base with residents and families. Anecdotally, we've had really great feedback from our families about appreciation of the communication they received as things were changing, the support that they felt. They didn't feel alone in watching their loved one decline. They felt very much supported. And along the journey, they felt that they were better connected to the team and felt very open to asking questions. And kind of help just to create a really good relationship between us and our families.
Okay, so that concludes the education component. I'll kind of pass it back to Amrit to start our question and answer session.
Thank you, Heather and Stephanie, for your presentation. It was really insightful. Um, we also wanted to send out a massive thank you to our sponsors for their invaluable support. We will now start the question and answer portion, and I do have some questions in the Q&A that have been posted already, so I will read them out. Some of them have pretty much the same theme around. So let me go in and so I'll kind of combine a couple of different questions because they're about the same topic. Heather and Stephanie, how often are you reassessing the PPS score? And is there a baseline PPS score that would trigger you to initiate a palliative care conference?
Good questions. Yes. So typically, our policy outlines that we assess at admission, a PPS score at admission to obtain a baseline. And then we had trial doing it quarterly thereafter, but it did require a bit more tracking and documentation. But because the PPS is very easy to fill out, we do use it as more of a communication tool rather than a documented number every quarter. So when someone starts to change, if there's been a change in diagnosis or if they've returned from hospital or if their ADLs changed to a degree where we're doing a RI assessment, then we would redo the PPS at that point. And then if they are 30% for the first time, we do the PPS repeatedly for 3 weeks just to see if they're stabilizing at 30% or if they're transitioning more towards end of life. If we start to see the PPS drop in any of those 3 monitoring sessions within the 3 weeks, then we know that we can't wait. So we wouldn't continue for the 3 weeks. We would then drop them down to 20 and we would know that someone is declining. At 30%, if someone's hit 30% for the first time, that would trigger us to do a goals of care conference. We used to call it a palliative care conference, but we call it more goals of care at this point because it's trying to just understand what people would like, educating them about where they are in their disease trajectory, and then discussing wishes. So those wishes could be different for everyone. We're obviously promoting more of a comfort approach if aggressive measures are very concerning, but we provide the education and obviously allow the resident and the family to decide. So we may classify in their care plan that they're receiving palliative care after that goals of care conference, or they may be receiving end of life care depending on how fast things are moving within the disease trajectory. Stephanie, did you have anything else to add there?
Just to kind of piggyback on the discussion. So I don't know, I don't think this came up as during our presentation, but something that these conversations help with are avoiding those 2 o'clock in the morning calls from the night nurse to the POA to say, we can't wake your mom up, or she's not breathing well. Do you want to send her to hospital? And then the families, are unsure, and yes, of course, yes. So if, we have those conversations early and say it's expected that your mom will have trouble breathing, or, she's going to get more tired, then we stop those kind of panic phone calls, and they'll know, yeah, the team explained that she will have trouble breathing, and no, leave her there, and can you provide some control, and kind of go from there. So yeah, getting a handle on and checking that PPS once there's changes, and talking to families can help in that way.
Thank you. So a couple of more questions around the palliative care end of life committee. Do you have terms of reference for this committee? Who leads the meeting? And how do you ensure that the interdisciplinary team participates and is properly prepared for this meeting? Great questions.
That is. Stephanie, did you want to tackle that first, or did you want me to?
Sure. So I'll just do the first bit. So yes, we do have terms of reference. So if they're okay to be sent out, then I'm sure we can send them out with some of the stuff we're sending out, just as a background if you're starting your team. I generally chair the meetings. it has been back and forth. Our social worker chaired it for a long time, and then I kind of took over a little bit. And we also have that clinical lead position, that RPN. So in different homes across our municipality, it's the same format. So the region of Durham, so we have other municipal homes, and their clinical lead chairs their meetings. So it varies depending. I do it because it's a passion as well. So I'm highly passionate about it. So that's why I kind of started to take over that group. I think the second part of the question was, how do you make sure people come to the meetings, or how do you make sure they're engaged? Fortunately, most of our allies are very like-minded. They're very passionate about this topic, so it's not too much of a hard sell. I don't know, Heather, if you have anything to add about engaging our team members.
Yes, I think, I mean, obviously we when we ask others to join, so PSWs, for example, we do try to, we put it out to the larger masses to ask who would like to be on the team, but we do tend to get people interested that actually have a passion or an interest for palliative and end-of-life care, or a drive to learn more. So you do have to have, obviously, buy-in from your whole leadership team. And that is something that you may need to start by educating your leadership team about why it's so important to focus on palliative and end-of-life care. As we know, in long-term care, there's so many competing priorities. So there are some times where priorities will shift. If there's a group of people, a group of team members within your home that are really wanting to improve your palliative and end-of-life care program, we would suggest starting with educating your leadership teams about the importance, so that you get the support for scheduling people to attend these meetings, assigning champions or leads. You can do that kind of model as well. You might have one or two PSWs attend, and then they also update other PSWs with what they're learning or what they're seeing. And then we include our allied health members, and we do our formal meeting once a month, because we do feel like that's realistic. We do try to come together, as Stephanie mentioned, if there's somebody that's declining. But what we do is we might not pull the whole team together, depending on what the needs are of that resident. So we might just pull 3 or 4 people to this care conference if we don't feel like we can get the entire group together. So there is ways to work around it. Obviously, resources and availability is an issue, but starting by empowering your teams to highlight the importance of palliative and end-of-life care. And then also like highlighting the stats that could change down the line. So reducing those hospital transfers, that's a big thing in long-term care. You know, that is something that's top of mind. So if enhancing your palliative and end-of-life care program can help with that, you know, we would strongly encourage you to kind of take a focus on what people might resonate with. Because some people might not resonate with the direct care, but they may resonate with some of the positive outcomes that you could see with enhancing your program.
Thank you, Heather. So a couple of more questions. If the residents get a PPS score of 30% and they are on comfort feeding, would you require a monthly wait for those residents to be completed? That's one. And the second question around the same topic is, if the residents with the PPS score of 30% are receiving supplements but are refusing, would you shift them to comfort feeding at that time?
So comfort feeding is a choice, and it can occur in anyone's disease trajectory. So someone could really have poor appetite issues, even when their activities of daily living are fairly high. So they might not be total fed, but their appetite is still very poor. So the key is having those goals of care conversations around nutrition and hydration at any stage, but knowing that those conversations early are important to have so that you know what's important to that resident. If you can't converse with that resident, then obviously talking with the substitute decision makers and the POAs. As for monthly weights, again, it's very up to whether or not that indicator is going to provide a benefit. So same with doing blood work or ordering an X-ray. We only want to do things when they actually show us benefit. So if we know that weight loss is expected and that someone is not going to eat and drink very much, that they're only going to eat and drink when they feel like it, we have those conversations around what that looks like. And then we also have those conversations around why it wouldn't be relevant to monitor those things anymore, just from a quality of life perspective. If we choose not to do weights and the resident or POA is okay with that, then we remove that from our task system. So we would basically turn that off for the PSWs, but then we would do a note to indicate why, and we would make sure that we indicated why in the care plan as well, because we do want to be transparent that we're not obtaining the monthly weight, but that we have a valid reason to do that. As for supplements, again, same concept. We have some residents that are on supplements right up until the end because it's something that they either enjoyed or they take well and family would like to see that provided. Or we have residents that really don't like them and we have conversations around, is this meaningful or is this helpful at this time? And then it's up to them to make that choice. Typically, I don't recommend oral nutritional supplements at end of life, but sometimes it's very important to people to receive those things. It also might be important for family to feel like that they're trying something. Ultimately, a small dose of an oral nutritional supplement isn't going to change the path or the course of the disease trajectory. So just making sure that the reason why we're providing it is in a comfort way, and then also isn't causing any distress. If we're seeing distress, then we want to have conversations around, why we wouldn't push or why we wouldn't provide in that point, and then talk about it from there. I don't know if that makes sense.
It
Yeah.
does.
Okay.
Thank you.
I tend to ramble.
There's a follow-up question from the first question, which talked about how often the PPS assessment was completed. And you had mentioned for first 3 weeks it was regularly. So the question is that weekly or daily for the first 3 weeks?
Sorry, yes, it's weekly. So we have it programmed into our electronic health record that you fill it out and then it automatically triggers the RN to do it 7 days later. They can do it at any time though. So what people are trained to do is that you do one, it goes into the system so that people can see it. But then they're monitoring that resident from shift to shift, from day to day. If they see dramatic changes, they can update the PPS at any time. But if they're not seeing any changes, it will prompt them to do it 7 days later.
Okay, thank you. Do you have do you have strategies that you can use on the care plan for residents who are receiving palliative care and end-of-life care?
So what we did as a group is as our divisional group, we kind of brainstormed how to capture palliative care and how to capture end-of-life care. And this is more from an interdisciplinary perspective. So what we typically do is if we've had goals of care conversations and the person has chosen a comfort measures approach or a palliative care approach, we would then initiate a palliative care focus within the care plan. And then it outlines, basically matches our policy with some of the things that we would watch for while someone is receiving palliative care. So symptom control issues, whether or not they can take their medications orally, just monitoring for that. Whether or not spiritual referrals need to be sent, and then also indicating if we've had that care conference and the date that was and what the goals of care were. So no hospital transfer, or doesn't want any artificial nutrition and hydration, and so on. So we would clearly outline that so that everyone on the team, the medical team and the nursing team and so on, can see that. And then as someone transitions more towards end of life, we would remove that focus and change it to the end of life care focus. And then we would pulls interventions from our policy that we do at end of life, which again can be updated to provide individualized interventions from there. And then within my aspect of the care plan, so if I'm looking strictly at nutrition and hydration, I might be adjusting the weight section of the care plan, or I might be adjusting the intake section. We have a focus that says unable to meet food and nutrition needs, or food and, sorry, I think it's like nutrition and hydration needs due to end stage illness. So I might initiate that focus within the care plan so that it's clear that this person isn't able to meet their requirements.
Thank you. And one last question. I think we've addressed all of them. Do you also use CHESS and PSI assessments as part of your palliative care?
We do use the CHESS scores. So as a part of our palliative care committee where we meet monthly, we do have our RI coordinator that does attend. And she will bring us CHESS scores from within that last month of people that have had RI assessments done. I don't love the CHESS score. The CHESS score is a moment in time, and the PPS is ever evolving. And if the person's RI assessment was done 3 months ago, then that CHESS score is quite old. However, it does give you an idea of where to start. So we use the CHESS scores if someone has a CHESS score of 3 or higher. We'll use that as something that our RI coordinator will bring to our attention in our group meeting, so that if we haven't already commented on the resident, we could say, oh, maybe this person needs to be on our radar because their CHESS score is now 3. So we do use that in combination with the PPS score. The PPS score is more real-time information, and the CHESS score would be showing you more of a change over time with the RI assessments.
Perfect. Well, if there are no more questions, I guess it's time to wrap up. I don't have any questions coming through the Q&A session. Perfect. Okay, well, a big thank you to all of the participants who made time for attending today, and a big thank you to Heather and Stephanie for this great presentation, and all of the great questions that came through. Please keep an eye out for the survey links we'll be sending your way. It's really important to get your feedback, so it helps us improve and tailor our future events to your interests. And we definitely and genuinely want to hear from you. I think that's everything. Oh, yeah, I just wanted to also bring up our upcoming webinars that for March 26th and April 24th. And again, a really great topics and very relevant to long-term care. So please do visit the OSNAC website and register, and they are free, bonus. We will be sending out the link to the recording, so stay tuned. And we will be sending out the survey for feedback, so stay tuned. And thank you, everyone.
Thank you.